for joining us. Today we're going to be talking about IBS for the practitioner. Dr. Christine Kadykalo is going to be doing the talk for us. I'm Dr. Jennifer Tanner. I'm one of the co-founders of the Tummy Clinic. But let's introduce Dr. Christine. Christine is a naturopathic doctor with almost a decade of experience. She spent most of her career in Portland, Oregon, working in a busy family medicine practice with a focus on individualized nutrition. She believes gastrointestinal health is essential to the whole body health and optimal functioning. Dr. Kadykalo incorporates evidence-based therapies with traditional healing methods. She's a yoga instructor, which encourages the learning of peace in mind and body. When not researching and practicing medicine, she is an avid snowboarder, surfer, and hiker. She's here to support you on your journey to optimal health and empowerment. Thank you for joining us, and you can take it from here.
Okay, great. All right. Thank you for the introduction, Dr. Tanner. Today I'm going to talk to you about IBS, what it is, diagnostic criteria, symptoms, and treatment, and then we'll go through a case and some questions. Okay. All right, what is IBS? So it's essentially abdominal pain with altered bowel habits, and sometimes there's bloating present. We do see it occur in about 12% of the general population. However, this number is even much higher in Canada. It's closer to 20%. And it is 2 times more common in women than it is in men. And so we diagnose it using the Rome 4 criteria. This includes having abdominal pain for at least 1 day a week for at least the last 3 months. And then it's also associated with 2 of the following stool patterns. So either pain with your bowel movement, change in stool frequency, or change in form or appearance of the stool. And then we can subcategorize it into the predominant stool pattern. So whether it's predominantly constipation, predominantly diarrhea, or mixed if it is a combo of the 2. IBS was once a diagnosis of exclusion, but now if they meet these criteria, they do have a diagnosis of IBS. It's still important to rule out any other potential causes of organic disease as part of your workup. However, that if they do meet these criteria, we can give them the diagnosis and start treatment for them. And so how do we diagnose functional GI disease? That is all clinically, basically the Rome 4 criteria that we used earlier. And what clues can we think of to make it know that it is more functional cause? We're looking at symptoms are changing, there is irregular patterns, it's often worse with stress. The onset is more gradual versus it being sudden. And it's usually going on since childhood, and it is lacking that organic disease cause. So looking at our diarrhea subtype, the most common cause of diarrhea in IBS is actually constipation. And so it's nice to know if it is true diarrhea that we're dealing with, which would present a bit more with like that empty feeling, maybe some associated symptoms of fever, body aches, or if it is a IBS from overflow constipation. In this case, they tend to feel a bit more bloated and full, and never have that sense of complete evacuation after a bowel movement. The true diarrhea is actually not the most common in IBS, and it does require a GI workup. So in this case, we are looking at testing things like celiac, the total IgA with celiac, but nowadays we are seeing most labs include those together. Fecal calprotectin to rule out inflammatory bowel disease. We're looking at a colonoscopy or biopsy to rule out any cancer. And then potentially looking at stool culture over in parasite. However, we usually only test those if there is reason to, such as if they had traveled to an endemic area or if they were camping. And then it's always good to look at the thyroid hormone too in both diarrhea and constipation, as this can alter the bowel habits. So this is just a nice diagram to help you understand that overflow diarrhea. Basically, we're seeing multiple little hard pellet stools stuck in the colon, and then it's only allowing water to pass through. This can be a nice visual that you use with your patients if you suspect they have this overflow diarrhea from constipation, because as you can imagine, it can be hard for them to believe that they actually have constipation when they're running to the bathroom with multiple watery stools throughout the day. So yeah, the visuals can always be great for that. And then our IBS constipation typically presents with bloating, pain, and nausea. They can have alternating bowel habits too. And unlike diarrhea, constipation is almost always functional. However, if they are presenting with some red flags of sudden weight loss, rectal bleeding, or it's acute onset, we do want to make sure to rule out certain things such as cancer, hypothyroid, maybe a neurological disorder such as Parkinson's or MS, and then assessing for an anal fissure if there is rectal bleeding. It may also be worth checking calcium, as high calcium can be a contributor of constipation. And then if they're bloated as well, typically that tends to resolve when we treat the constipation. However, if not, we can look at doing an abdominal ultrasound, assessing the ovaries, gallbladder, pancreas, especially if they haven't been worked up for this before. And so some possible causes of IBS, truly we don't always know, but there can be various factors that are contributing, such as after an infection, maybe alterations to their gut microbiome, after surgery or heavy antibiotic use, different food sensitivities or intolerances, the gut-brain interaction and visceral hypersensitivity. So we're learning a lot more about this now and how it is a big predominant contributor. Stress, the GI motility, and genetics. So for my approach is really to get a good history and understand what's going on, know the baseline and then any changes in their bowel habits, understanding if the symptom is daily or what a typical week or month might look like. And then really understanding if it's true diarrhea, and if so, work up and refer appropriately for that. And don't just always assume that it's IBS diarrhea. So the treatment approach, it'll vary a little bit based on the subtype of IBS. However, in constipation, we're really looking at just getting that block stool out, getting that river moving. So we're using osmotic laxatives such as PEG or magnesium. And then we can start to layer in fibers such as psyllium. If they're failing any of those treatments, we can look at using medications such as Constella. And then always assessing the pelvic floor too and referring appropriately to pelvic floor physiotherapist if this may be a contributing factor. In diarrhea, we're using fiber, FODMAP diet, probiotics, potentially medications such as rifaximin. And with pain, peppermint oil has been very well researched here, various medications such as amitriptyline, and then for bloating, FODMAP, probiotics, and rifaximin as well. And we'll get into all of these in a little bit more detail coming up here. So this is the IBS algorithm put out by the Journal of Canadian Association of Gastroenterology. And so essentially, yeah, we're ruling out for any organic disease first, celiac, running a colonoscopy, especially if it's new onset or if they're greater than 50 years old. And then from here, the treatments are fiber, peppermint oil, and then different based on the IBS subcategory and using our FODMAP diet or medications, and then CBT and hypnotherapy. And so typically when patients see their GI doctor, they are recommended Metamucil and peppermint oil. Sometimes we see these patients where it's not always effective because they don't all know all the details of how and when to take them. And this is where naturopathic doctors are helpful. We can go over the nuances, dosing, timing, and adjustments of those. We have the time to do so with the patients. You'll often see that they feel more is better at first with the fiber, but sometimes they actually need to scale back a little and then increase the dose slowly or use it at incorporate it at a different time. So we can help them manage all of those details. So the goals with our IBS patients is the big thing is education, really helping them to better understand their IBS. Reducing anxiety around food and diet. So we see these patients are they're often performing avoidance behaviors. So they're not going out for social events anymore. Maybe they've stopped traveling. In extreme cases, sometimes they're not even leaving the house anymore. And then beyond that, we want to just support their gastrointestinal motility and provide them with tools to help manage this discomfort. And overall, we're just looking for a better quality of life. So some lifestyle factors that we want to address. We do want to make sure they're always getting adequate fluids, especially in the constipation subtype. We're aiming for 2 to 3 liters of water per day. Meal timing. So this is an interesting piece where The whole migratory complex of the digestive tract takes about 2 hours. So if someone is having a meal and then snacking pretty quickly after, they're resetting that whole migratory complex, and then that can just kind of wreak havoc on the digestive system. So if they are a frequent snacker, making sure there is at least 2 hours between the meal or the snack. We also want to identify food triggers, and this is where we use the FODMAP diet, making sure they are taking in adequate soluble fiber. Kiwi is a wonderful fruit where we have some pretty good research showing that 2 kiwi fruit per day improves constipation and abdominal pain. It even outperformed with psyllium and prunes for bloating, so that's got some pretty good success. And then looking at sleep hygiene and circadian rhythm. So our body loves rhythms, and our digestive tract works on these rhythms as well. This is why we tend to see problem in those who are traveling, especially when they're going across time zones. And we see issues a lot in shift workers too. So when possible, really looking at having a consistent sleep-wake cycle, consistent meal timing, and that can really help with bowel regularity as well. Physical activity, particularly walking and yoga, movement really supports the physical component of the digestive tract. And then meditation or any other tools to really help calm and regulate that nervous system. So the FODMAP diet, this is the standard of care in IBS and is supported by multiple clinical trials. FODMAP stands for fermented oligosaccharides, disaccharides, monosaccharides, and polyols. So it's a big mouthful. And it's undigestible sugars that can cause pain and bloating from gas. IBS patients are often more sensitive to these foods because of the imbalances in their gut bacteria and the hypersensitivity to the gas buildup. So typically we put patients on this diet for a 2 to 6 week trial. It is by no means a lifelong diet. We have two goals, one being to help make changes to the gut microbiota, and then two is to identify food triggers specific to that patient. The diet can be challenging because it's not necessarily black or white. Like some foods will be a little higher FODMAP or lower FODMAP based on their ripeness or based on their processing. So at the Tummy Clinic, we do have a dietitian that is Monash University trained, and they can help guide patients through these diets by using certain meal plans and recipes. The Monash University is where all these guidelines come from and where they're constantly updating the foods. They do even have an app, which is a wonderful resource. On there, you'll find foods that are which are okay with those that aren't. They even have some recipes and areas where you can make diary notes and track your symptoms too. And one other note about the FODMAP diet is it's really important to always have a plan for the reintroduction phase after the elimination aspect, because our long-term goal is food diversity to build a healthy microbiome versus kind of narrowing and isolating the foods. So then looking at some supplementation options. So the magnesium and PEG are kind of our choices for osmotic laxatives in constipation-prone cases. PEG is the same as Restorelax. And in magnesium, this is where we actually want to use more of our not well absorbed forms like the citrate or oxide, because we are looking for that kind of osmotic stool effect versus this is not really a place you'd want to use some of those like the bisglycinate. You'd have to use much higher doses to get the same effect. And then peppermint oil, one of probably our best researched items in IBS. It's an antispasmodic for pain and bloating. Really helps to relax those smooth muscles for pain relief and cramping. We can use it symptomatically or preventatively as we're going through a FODMAP diet. It does have a couple of side effects of heartburn and burping. So just be cautious here not to use the peppermint oil in someone who already has acid reflux. And then fiber, we want to kind of layer this in once the stools are moving to get bulk into the stools, make sure that we're maintaining bowel regularity long term. Make sure that you do always start slow with fiber and then kind of build it up. Otherwise, if we use too much too quickly, it can sometimes make things worse. Um, Really with fibers, we're aiming to get 20 to 30 grams per day. So partially from food, but then we can use the psyllium or the hydrolyzed guar gum as substitutes. And these two tend to be the best tolerated in IBS. With the probiotics, they can help improve the intestinal barrier, modulate the immune system, and regulate transit time. We do want to be intentional with strain for probiotics because different strains are researched for different conditions and symptoms. So it's not always helpful to just use a generalized probiotic or a multi-strain. You will not have as good an effect with that. I really like the resource, the probioticchart.ca. On there, they have a list of all the different strains and what they've been researched for. And then ginger, really soothing to the GI system, brings down inflammation and can be helpful for motility. The digestive enzymes we're really using more just for symptom management, if they're eating out, having big meals or traveling, just to help them break down their food intolerances. It might also be worth mentioning vitamin D because that can be helpful to test and treat, especially if there is a vitamin D deficiency, because we do often see lower levels in those with IBS, maybe because of the malabsorption, if they're avoiding certain foods, maybe they're not spending as much time outside. And we're looking at the research did use, it was 50,000 IU per week or 2,000 IU daily for 6 months. So then the disorders of gut-brain interaction. This plays a huge role in IBS, and we're finally just really better understanding this component. It's when messages between the gut and the brain are misinterpreted, and this can lead to pain, constipation, or diarrhea. We have a couple of tools to help address this. We've got the cognitive behavioral therapy or gut-directed hypnotherapy. CBT can be used to retrain that nervous system pathway. Patients, they often develop these avoidance behaviors. They develop fear-based behaviors because of their symptoms. So it can be nice to address these aspects of health. The CBT is typically done in a 6-week program, and we see some pretty good symptom reduction with that. There are therapists that are specifically trained in CBT for IBS. If the patient does not have access to CBT, then really enforcing the mindfulness component because that's what is most therapeutic. So they can do meditation at home or journaling. Journaling about IBS symptoms has also been shown to be really helpful to reduce symptoms. And then as far as the hypnotherapy, so there's an app called Nerva, and it's something that you can just download on your phone, and they use evidence-based techniques to help address this miscommunication pattern. They even did a trial that showed that majority of their participants that went through this had relief in their IBS symptoms. It's also a 6-week program. And I would say probably the biggest challenge around this is patient compliance, just because it can start to feel a little repetitive. They're just listening to a recording every night before bed. But if they do follow through with it, we tend to see some really good results. And just some comorbidities to mention. So anxiety, insomnia are common. Also endometriosis, just given the location of everything in the pelvic region. So this is one that I just wanted to kind of note that if you are dealing with a patient with endometriosis, it's always good to work up for IBS as well, because if you diagnose and treat that together, you often will have some better success there. Okay, so let's go through a case. So this is a 30-year-old female. She presented with diarrhea of 3 to 5 bowel movements per day. She also had abdominal pain, bloating, nausea, and reflux. These symptoms were starting to cause low mood because it was affecting her quality of life. It has been going on for the last 5 years, and even worse in this past year. So what else do we want to know about this case? So upon further questioning, we understand that she's a nurse and she does shift work. So we already know her circadian rhythm is affected and she is under some high stress. Her loose stools are actually Bristol stool chart 5, so they're a bit more semi-formed versus liquid diarrhea. Her pain and bloating is improved with bowel movements. So this kind of triggers us to think that maybe there is an underlying constipation that's presenting as overflow diarrhea. And she has tried various medications such as a PPI, metoclopramide, and Tums without much success. And here's a diagram of the Bristol stool chart if you have not seen this before. This can be a really helpful tool to use when you're asking patients about their bowel patterns. Way more often than not, I have patients say that things are normal and then they tend to be either a type 1 or 6 or vice versa. So it can really just help you to understand where they are at visually, because oftentimes patients don't even know what is considered one or the other. So some tests that she's had over the years, she has been screened for celiac. Her calprotectin was negative. She had a parasite testing and that was negative. Her blood cell count and thyroid were also normal. So at this point, we're fairly confident that she is dealing with a functional GI disorder. And so what kind of treatments would we be looking at? So to treat the constipation, that's the first thing we want to address. So in this case, I recommended PEG, 1 capsule daily. I often do give patients a choice of the PEG or the magnesium citrate. And then we incorporated psyllium, starting at a low dose of 1 teaspoon and slowly increasing up to the 1 or 2 tablespoons. Also incorporated ginger to help with the motility and inflammation. And then prescribed a low FODMAP diet for 2 weeks to see what there was for possible food triggers. And then also made sure to address her stress. So it taught her some diaphragmatic breathing exercises and then referred her for CBT as well. At her follow-up, her bowel movements are now 2 times per day. They are more formed. However, she does still skip 1 to 2 days in the week. The pain is much better, but the bloating is still there. So at this point, I increased the osmotic laxative, in this case, layered in some magnesium citrate. We could also think about using peppermint oil in some cases, but here I did not because she is prone to the acid reflux. And then with the diet, we started to do a slow reintroduction of the foods. And by doing so, we identified that onion and lactose were big contributors to her bloating. I recommended that she stay off these foods for now. We can always re-challenge them later because the microbiome is always changing. And then our main goal is just focus on expanding the plant foods to just help create a healthy microbiome. And then just a little note on constipation, that if we are using our treatments and it's not really moving that well, we can use some medications. So looking at either Constella or Resotren. And then a clinical pearl from one of our gastroenterologists is that when they get these patients, they will always suggest the same treatment, but often just more of it and for longer. So sometimes it can just take a little more time or aggressive treatment to get that constipation moving. And if the bloating were to persist, that typically tells us that there is more backup of stool that needs to move out. So we just treat that constipation a bit more aggressively. If we're unsure, we can always get an abdominal x-ray. So this will show if there is any fecal loading or stool impaction, and can help kind of push through that constipation treatment. Otherwise, we might want to consider an abdominal or pelvic ultrasound or test for H. pylori. If all of those are negative, then that would be a time to consider rifaximin. So rifaximin being our antibiotic, best known for SIBO. In this case, though, we don't necessarily have to have a positive SIBO test to administer rifaximin. As we saw earlier in the guidelines, it is a part of the recommended treatment in IBS. And the testing for SIBO can be a little bit tricky as there is often some false positives and negatives. So not always that helpful. So back to our case at her next check-in, her bowels are moving pretty well, 1 to 2 times per day. They are well formed and easy to pass. She's not experiencing any bloating except for if she does eat onions and lactose. She's not having any nausea. And then she just has some occasional reflux when she's lying down after eating. So this is a good time to kind of manage expectations, letting her know that, lifestyle stuff, that if she is lying down right after eating, there is likely a chance of reflux. So just trying to avoid those behaviors. And then just a little side note too, the gas wasn't a big part of this case, but a lot of times people are concerned that they're still passing gas, but it is actually normal to eliminate. It's up to half to 1.5 liters of gas per day. And that is just it for any normal case. But otherwise for her, so our future plan is focusing on gut health maintenance. So we're using pre and probiotics from food, fiber, healthy fats. 30 different plants per week is our best tool for a strong gut microbiome. So this includes anything from fruits, vegetables, ancient grains, nuts, seeds, and legumes. And really our goal is just to have her eat the most variety of food with the least amount of symptoms. So even if that is different foods in just small amounts, that's always a great tool. And then making sure that she does continue her breathing exercises as long as she is still in a stressful environment. And then ensuring that she uses the PEG and magnesium whenever the stools do start to get hard, because we really want to prevent that constipation before it gets bad. All right. So just ending off on some pearls, the goal of treating constipation is really to prevent it. Don't wait until it gets bad. Take the supplements or meds daily or every other day to just prevent that constipation. IBS diarrhea is a more unlikely diagnosis, so making sure you are either working up properly or assessing for a potential underlying constipation. History is the most important part. Ask lots and lots of questions. And persistent bloating is likely not an infectious disease, but usually more functional or constipation related. Right. And just a note about the tummy clinic. So we are a virtual care clinic that specializes in IBS and functional GI disorders. The program was designed by our gastroenterologist from Ontario. And they designed it because they saw the need for collaborative evidence-based care with allied health experts. So we are a team of naturopathic doctors, dietitians, psychologists, along with the GI docs. And we are fully virtual, serving patients all across Canada. All right, so thank you so much for attending our lunchtime talk. If you do have any questions or if you want to collaborate on any cases, feel free to email me. I have my email on this last slide here, and then we can get to any questions.
Thank you so much, Dr. Christine. That was wonderful. If anyone has questions, just feel free to type them into the chat. And there is one here about magnesium. Do you have a recommended dose that you use for constipation?
So yeah, it is very patient dependent. Typically, I'll start them off at around 300 milligrams, and then we do want to increase by either one capsule. Usually it's around 150 milligrams per capsule each night until we get the desired outcome, which is a full complete stool elimination. Sometimes it does get a little bit loose, and then we can back off from there. But yeah, essentially we're starting around the 300 milligrams and then stepwising up based on how much stool is backed up and needs to be evacuated.
Great. And if there is somebody that we're not sure if would be a good match for the tummy clinic or family doctor, when do we know to refer?
Yeah, so if they've already seen a GI, that's a wonderful time to refer to a naturopathic doctor. It means they've already had all of that workup. If they are presenting with any of those red flags mentioned, so if they're rapidly losing weight, if they're bleeding, if the onset was sudden, or if they're over the age of 50, you may want to look at referring to their medical doctor first. However, we can always assess them as well. And if we find that those are concerns, naturopathic doctors will also refer appropriately from there.
That's great. And just to tag on to that, if you in your clinic are thinking that you have somebody that you're not sure about, they can always book a discovery call with one of our practitioners to see if they are a good match, or give the clinic a ring, and admin can help them troubleshoot. We do have a referral letter on our website under the contact us section that you're welcome to fill out. Patients can also self-refer, so you don't have to fill out the referral letter. It just gives us a little background before we get started with them. So thank you again for everybody for joining us. Just as a reminder, as to the practitioners that we have here, we do have the psychotherapists, dietitians, naturopathic doctors. In Ontario, we have nurse practitioner as well, and we are available in multiple provinces throughout Canada. So thank you again for your time, and thank you again, Dr. Christine.
All right, thank you so much.